popping any questions or any ambition statements in Slido. I just want to take the time to introduce our amazing panelists. So we have Selina, Tara, Deb and Steve, who presented their projects, as well as Jane and Mel. And we also have Chris Strether, who is the Regional Medical Director for NHS England London as well, joining us today on the panel. So this is just an opportunity for the next 20 minutes to ask any questions for the project presenters around their projects that they shared, but also to have a bit more of a broad discussion around personalised care and secondary care as well. So any wider questions or topics you want to discuss, please feel free to raise your hand and ask questions, or pop questions in the chat as well. Yeah, Jagan.
Hi everyone, thank you. Can you hear me?
Yeah, we can hear you.
Yeah, great, thank you. Just one of my questions be, what do you think the greatest challenge was to introducing personalised care roles into your services? I mean, because obviously it's quite new in some respects to secondary care. So just wanted to hear your view on that. Thanks.
Thanks, Jagan. Who would like to answer from the project presentations?
I can start if you'd like.
Sure, yeah, go for it, Tara.
I think the fact that social prescribers are something that isn't entirely familiar within the secondary care team, and that it's an so far unregulated profession, makes it really difficult for HR to wrap their head around what a social prescriber is. And even coming down to like the DBS checks, we had a big discussion about whether or not someone was going to have patient contact and what kind of DBS checks they would need. So all of these things are so new that it really felt like we were inventing something rather than just introducing it. And then, of course, in addition to that, the fact that so much of the funding available for projects like this is one yearly. It really makes our ability to evidence outcomes, which are going to be, by nature of the outcomes, long-term, really quite challenging. So I find that I have now given the entire work of the project for patient care over to Remy and our social prescriber and the whole welfare team, and I'm just fundraising. So it's I think those are probably the two larger challenges.
Great, thanks, Tara. Yeah, Jane.
Just the first part of that about how you employ social prescribers. I mean, if one person has done it, we should be able to share with the rest. So I don't know whether there's some FAQs that could help, kickstart if those things are really causing barriers to doing this.
We certainly have shared our job descriptions for the adverts with all the other people who are working at Barts and employing, and happy to do it for others.
That's great.
Great, thanks, Tara. Yeah, Joe.
Thanks, Molly. Thanks, everyone. It was absolutely fantastic webinar. So really happy. It's so amazing to see so many people on the call as well. So I guess my question was just around the impact these roles have had. How do you feel having these roles available has impacted on your ability to really care for your patients?
I'd prefer to answer that one. That's helpful. I mean, I think for us, the chronic pain patients are so complex that I think traditionally they would have just come and seen the GP, and the GP would have there would have been an expectation the GP can sort everything, and actually I think having all these additional roles, we can't. And now I think working as part of the team with all these different personalised care roles, we understand we can't. And actually I know my role as the GP, but I now understand what the social prescriber can do to help, what the health coach can do, what the pharmacist can do, what our secondary care colleagues can do. And I think the real thing is actually it's about using all the knowledges and skills and experiences that we have in the room more effectively, and recognising that actually the social prescribers have these incredible skills and fountain of knowledge that's much better than I have. I can do some things, they can do other things, and it's really giving everyone an equal footing to support these patients for all the stuff they need. So yes, they have medical needs, but they have all these other needs as well. So it's kind of recognising the different roles that everyone can play, and then supporting the patients with that. And they like that as well. The patients really like the fact they're cared for by a team that are all talking to each other and working together. So for me, it's just about recognising the skills that are in the room and making use of them.
If I can add to that.
Sorry. Yeah.
I think that there's been a knock-on effect in the rest of the team as well, for our safeguarding team and our ACPs and our the psychologists, starting to be able to address these social welfare needs that were something that we couldn't address before. As they tell me, I don't want to speak on their behalf, but they tell me has improved their day-to-day work as well, which is nice.
Great, thanks Tara, that's really, really nice to hear as well, for sure. And great always, I think, to get that, ensure continually getting that kind of patient feedback. So we've got a few questions in the chat, but I'll first come to Mark, and then we'll go to some questions in the chat, and then I'll come back to other people with their hands up, if that's okay. But yeah, Mark. Thank you.
Hi. Actually, I did put my question in the chat as well. How can we make it easier to refer clients to social prescribing link workers for high intensity users? I appreciate that none of you are directly HIU. However, for me as a non-clinician piloting this project in South West London, it's sometimes difficult to differentiate or identify a suitable referral, and I don't want to raise the expectations of the client by contacting them in the first instance and then being unable to support. I just wondered if the panel had any ideas about what may be an easier way forward. Thank you.
Thanks, Mark. Does anyone like to jump in on that?
I haven't got an answer. But it's an issue that we need to address if it's difficult in practice. So I think we should have the wherewithal, shouldn't we, to make it as smooth and seamless as we can, using whether it's technology and all those great relationships. But other panelists have got their hands up now. They've had a chance to think.
Thank you.
Thanks, Jane. Yeah, Tara, I think you had your hand up.
So
first.
I think one of the things that we really, really need to all be asking for is a integrated directory of services where all of these things can quite easily be have referral pathways. And I think because everything's been so borough specific in the past and place specific in the past, it's really hard for a network like ours that spans 7 boroughs to really understand each of the different directory of services in each place. And so I think as a whole, those who are looking kind of strategically at it, Mark, your question is quite pertinent because it will address the needs that we have across the entire system in terms of more integration into the network.
Yeah, I mean, my concern is the fact that as a non-clinician, so I literally get sent a spreadsheet with name, date of birth, NHS number, and it may, or the number of attendances over the year, and then it may or may not have the reasons they had gone to the emergency department. And I think Google is a bit worn out now that I've had to try and Google as many medical codes as possible because all these acronyms, which I'm unfamiliar with, obviously. But perhaps in my experience, it is mental health issues and those that are still, active drug users or not sober, then obviously it's very difficult for me to engage at that point. And had I understood that client wasn't necessarily a relevant referral for me at this point and may need more specialist support, then it may make it easier for me to target those referrals that are more suitable for social prescribing. But I appreciate that it is an ongoing thing, and something I just may have to bear with for a while. But thank you for your thoughts.
Thanks, Mark. Yeah, and Cal wants also helpfully put in the chat as well that around the use of digital case management systems supporting the referral pathway. So, for example, Joy, which has been commissioned for all PCNs in North West London. Mel, did you want to come in on that question?
Yeah, I was going to come in on that one. For us, as we got to understand the needs, that the social prescriber who worked with us, actually, she became like a single point of access, and she built relationships across NCL that would be a useful offer for our patients, but she would always have to do a bit of a triage conversation with them. So what was easy for us was we had, one email, and then she took on the heavy lifting of mapping the individual's need to what was available across our ICS. But it was quite a shift for her compared to how she'd worked before, because previously she'd always worked with a Camden focus. But in sort of working and designing it together, that was just a really lovely resource to have access to.
Thanks, Mel. That's really helpful. Koji, I think you put a question in the chat and also have your hand up.
Thank you very much. As a link worker in the secondary mental health, it is really helpful. However, as I put the chat, not only me, we have still sometimes difficult time to back and forward with two systems to smooth referrals between primary and secondary. And I'm just wondering, listening to the oral conversation presentation, other parts of London, social prescribing or this kind of personalized care, do people use one system, or still kind of shifting between the different databases to understand how to follow the referral? That's my question.
Thanks, Koji. Tara, I know that you're looking into a lot of work around this. Did you want to come in on that?
I feel like I've been a real negative Nelly in this discussion. We've met quite a few challenges in digital integration, and there is a platform that connects all of the primary care team, and secondary care is, at least in North East London, is having a really hard time getting into it. But it's definitely needed.
Oops. Sorry. I'm just having some issues with the slides. We'll go to Mark. You've got your hand up as well. Thank you.
Hi there. It's another Mark.
Oh, right,
just to keep everybody on their toes. And even worse, it's an interloper from the Shires. This has been really interesting. I've done a lot of work around personalization more out in community primary care, and I guess the question that just came up to me when setting up these sorts of schemes, there's always a decision about, do you have your own social prescriber, or do you utilize the social prescribers within the primary care networks that were already there in the ERS roles? And I was just wondering how you decided, and then how and if they interface, because there's a lot of potential shared governance and also information sharing, which we just touched on. So I guess, how did you decide to go internal rather than maybe partnering up with a PCN and then working up those referral pathways?
Thanks, Mark. That's a really great question. I think highlighting how there's so many different ways that you can approach it in secondary care. Is there anyone from the panel who has any comments on that?
We've done it sort of both ways. So in our pilot project, we were in a single practice, and it was just the social prescriber within that practice that was part of the team, essentially. The sites that we've done as part of the expansions, some of them don't have a social prescriber at all, so I haven't been able to do it. But a couple of them in particular are actually part of very large PCNs, and they've been using their PCN social prescribers as part of the project. I think both have worked really, really well, to be honest. I think it really depends on kind of the practice, the ethos, what you're trying to do. I suppose the advantage of kind of using a broader, the social prescriber who works across the PCNs, I think is around this culture change. And I think that's what we're kind of all trying to do, and we're all talking about, is actually shifting the focus away from numbers very medical model to a much more personalised care model. And I think the advantage of involving PCN level pharmacists is that not pharmacists, sorry, social prescribers, is that actually they become part of the team, they recognise this role, and that spreads across more practices. So actually it means that each practice they're working in understands their role a bit better. So I think if we're looking at kind of shifting the culture of healthcare, which is what we're really sort of trying to do this more personalised approach, I think kind of the higher level you can do that, the better, provided that team member is still part of the team, is supported, because I think that's something we've definitely seen, is that making sure these social prescribers are actually supported in their roles and have got a clinical contact and supervision and that sort of thing as they need it. So I think both works. That was just our sort of experience from what we've done.
Thanks, Selina. Yeah, and I think it's really specific depending on the needs of the exact project, isn't it? And what works well for that particular area, as there is so much kind of complexity within secondary care. So I think in some cases it would work really, really well involving PCN social prescribers, and in others it's kind of better to have someone based in the ward, for example. I'll come to Beth. You've got your hand up for a question as well.
Thanks, Molly. I just wondered from the patient's perspective, how the panel have found the patient response to the offer of support from these roles when based in secondary care.
Has anyone got any kind of comments from patient case studies or feedback from their projects?
We're really early days, so we don't have a ton of patient feedback yet. And as I said, the patient-facing side of things is really our social prescriber and ACPs. But what they've told me is that even though we're identifying 1/3 of patients in the heart population who are having social deprivation difficulties or challenges, not all of them actually want help. And I think it's important to be able to differentiate that before you start offering help. But beyond that, I think they're expressing a little bit of surprise that we're asking, and then gratefulness that we're trying to help.
The feedback we're getting from the people we're supporting to get out of the hospital is obviously very good. We're able to speed up for them. There's one case study that springs to mind. He was unable to get up the stairs, very limited mobility. We met people delivering his equipment at his property, and then we were able to support him longer term. So we do lead walks in the borough. So we're able to accompany him to the lead walks. Now he does them every day. I don't know, people will know Greenwich Park. He's been able to walk around that. And before he couldn't walk to the shop at the corner of his road. So we're able to get around people and help with the long-term support as well from our social prescribers in the practices. It does make a massive difference.
Thanks, Steve. Yeah, and I know that you had some examples of kind of patient case studies and feedback on your slide as well, which we didn't manage to cover, but we'll be sharing that in the slides, so thank you. I think we'll probably have time for a couple more questions. I'll come to Dan first, because I know that, Dan, you've popped something in the chat a while ago. Do you want to share your question? Are you there, Dan? Did you have a question? Okay, I think we'll Katie, can I come to you and then maybe we'll come back to Dan?
Absolutely, thank you. So I think Jane sort of set out quite a lot of sort of options that we've got to sort of take forward the ambitions to embed sort of personalisation in secondary care going forwards. But I'd really value sort of thoughts and feedback from the panel about what you think we need to do to achieve that 2025 ambition, and who do we think needs to be involved to make it happen?
Thanks, Katie. Would anyone on the panel like to respond to that? Yeah, Chris.
So I'll say something because I haven't said anything yet, because quite a lot of the questions have been more appropriate for people who are actually doing it rather than people who sit in offices like me. I think I think there's a couple of things. There are so many people in the system that if we really embrace the opportunity that comes with this, could contribute and make a difference. But there's quite difficulty with all of us at the moment that everyone is so busy firefighting and doing what we've always done a bit harder because we've got a fed up workforce and not much resource. And I think there's probably a sort of leadership community job to say, actually just pause a little bit for breath and try and do some things like this which are different, which will have quite a quick return. Joe Fraser, who works with Jane on this in the London office, has presented some really exciting stuff on hypertension and picking out high risk populations and how you can make a real difference and get quite a rapid return on investment. So I think it's having the sort of almost the leadership nerve to sort of pause on the hamster wheel for a bit and try and do some stuff different. So I think events like this are useful, but we probably all need to go out and be ambassadors and champions for personalised care outside the meeting instead of all meeting, because when we're all meeting together like this, we all agree with each other anyway, don't we? So we probably need to go out and convert some of the sort of the less converted people, because it is a massive opportunity. And the final thing I think I may have missed it in the bits of the conversation I wasn't in, but I think there's also massive opportunity to engage communities in this, the sort of third sector and faith groups. We got really good stuff about vaccination during the COVID pandemic, but we probably haven't reaped the full benefit of working really closely with faith groups and community groups, and that's another way of us adding capacity to this and also spreading the word. Thanks.
Thanks, Chris. Yeah, no, really great points around, I guess, going out ourselves and really kind of championing this agenda among our different networks and continuing to do that following this meeting. Really, really important point, and definitely among kind of working better with the community as well, and particularly faith groups, I think really important as well. So thank you. So we've got about 1 minute left. So if it's okay, I think we'll pull together any further questions. If you can pop them in the chat if you haven't managed to ask them, and then we'll pull together a bit of further questions and ask those to the panel offline, if that's okay. But just to summarise, so hopefully I'm still sharing my screen. Yeah. Yeah, so please do continue following this session just to share any ambition statements you have in Slido. We'll be pulling these out in the following weeks and sharing with the slides, the recording and themes from the discussion during the panel as well. Please also fill out a short feedback form. This will really help us to improve any future events that we run, and also help shape regional support to help expand personalised care roles in secondary care going forward. And then just to say, in response to just to come off what Chris said as well, around little things that you can do to kind of further this agenda, particularly around kind of championing and advocating in your local networks, but also if you're interested to join the Pan London Community of Practice, you can reach out to Beth or I at the email addresses there. But yeah, I'll be sharing the slides in the next couple of weeks as well. But yeah, thank you everyone. Hope it's been a useful session, and yeah, hope you have a good rest of your afternoon.
Thank you, Molly.
Thank you very much.
Yeah, thank you,
all.
everyone.
Thanks.
Thanks,
Bye-bye.
everyone. Super stuff. Thank you. Bye.